Because the intrauterine environment is relatively hypoxemic, with the average umbilical vein PO2 being about 37 millimeters of mercury, there is physiological increase in fetal erythropoietin, so that the majority of term newborns are born with hematocrits in the 50s, the normal range being from 45 to 65. At the time of birth, the previous fetus, now newborn, enters an oxygen-rich environment, and this is a signal for a turnoff of erythropoietin, and that's exactly what happens. And with this, there's a progressive drop in hemoglobin over the first 2 to 3 months of life. If it were to continue past this point, down to about 7 to 9 grams per deciliter in a term infant, then tissue oxygen needs would not be met. So erythropoietin is turned back on, and the hemoglobin gradually returns to normal over the next 4 to 6 weeks. In term infants, we don't even see this. The babies are not hemodynamically compromised. They look fine, and nothing needs to be done about this. We don't typically check hemoglobin or hematocrit at that age. The problem occurs in preterm infants, and depending on how early they were born, it can be significant. This is rather a mood issue because many preterm infants, particularly those of extremely low birth weight, under 32 weeks, 30 weeks, are in neonatal intensive care units. They're often quite ill, and they have blood drawn and require frequent transfusions. This whole process then is known as physiological anemia of infancy. Iron deficiency in children has its highest incidence from about 6 months to 2 years, and then again in adolescence. Iron is needed for production of heme proteins, and a smaller amount of iron is stored as ferritin and hemosiderin. Storage depletion leads to anemia. The main cause in infancy is a decreased intake of iron, primarily with those children who are put on cow's milk inappropriately under 1 year of age, those with malabsorption, those with low iron diets beginning at 4 months of age for whatever reason, and those infants with increased needs, typically because of chronic hemolysis or blood loss. Adolescents generally have a high requirement for iron because of growth, and in females due to menstruation. The major signs and symptoms are lethargy, decreased appetite, irritability. Young children can have pica, which of course is the inappropriate eating of non-nutritional material. They can have behavioral changes, pallor, stomatitis, tachycardia, a systolic flow murmur, and even in severe cases, decreased blood pressure and heart failure. Iron deficiency anemia produces a microcytic hypochromic anemia of underproduction, so there's a decreased MCV and a decrease in reticulocytes. When looking at the smear, we usually refer to the way that the red cells look as anisocytosis, which is variable size of the red blood cells, and that means the RDW, the red cell distribution width, can be anywhere from normal to more commonly increased. Additional studies would show an increase in free erythrocyte protoporphyrin to some degree, a decrease in serum iron and ferritin, decreased transferrin saturation, and increased in total iron binding capacity. If the diagnosis is suggested, the most cost-effective first step in management is to simply give a trial of iron replacement for a month. With this, if it is truly iron deficiency, you should see a reticulocytosis within the first week, so a repeat reticulocyte count is often obtained in the next 5 to 7 days after the start of the iron. Thereafter, the hemoglobin should start to increase by at least 1 gram per deciliter over the course of a month. If this doesn't happen, then it is not iron deficiency anemia, assuming that the patient took the iron as indicated. If not, then other causes should be considered, such as thalassemia, lead poisoning, or anemia of chronic disease, in which case it is more cost-effective at this time now to perform other iron studies. The iron is continued for another 3 months to replenish iron stores. Lead poisoning remains prevalent in the United States. The highest risk is in toddlers who developmentally put things into their mouths normally. Older buildings may still have leaded paint. Some glass, batteries, cosmetics, jewelries, toys, pottery, lead soldering on water pipes, and airborne contamination from factories that smelt lead. Also through inhalation and transdermal absorption. The upper limit of normal now for blood lead level is no higher than 5 micrograms per deciliter. This was just recently brought down from 10 by the Centers for Disease Control. Higher risk occurs in minorities and in people with lower socioeconomic status. Most lead is sequestered in bone, in fact, for several years, the rest to the blood and soft tissues. Increasing lead interferes with heme synthesis at 3 enzymatic steps so that hemoglobin is decreased and there are increased toxic products. The clinical presentation at higher lead levels that found at the time that most children are diagnosed are decreased appetite, abdominal pain, constipation, possible pica, pallor and fatigue because of anemia, and neurobehavioral behavioral changes, which include hyperactivity, inattention, personality changes, changes in school performance. At levels greater than 70 and always greater than 100 micrograms per deciliter, we see lead encephalopathy, which primarily consists of vomiting, papilledema, ataxia, seizures, decreased consciousness, hypertension, bradycardia, decreased respiratory effort, coma, and death. On the physical examination, lead lines may be seen on the gingiva or in the epiphyses, particularly in the distal femur and proximal tibia if x-rays are taken. Children who are at increased risk, that is, young children, particularly low socioeconomic status, living in older buildings in urban areas, and particularly those who have immigrated from other countries recently where other countries may still have leaded paint and lead and gasoline, are targeted for blood lead level screening at the 12 and 24-month well child care visit. When they are found to have increased lead levels, this should lead the pediatrician to get a good venous sample for blood lead level, which is the gold standard. Lead produces a hypochromic microcytic anemia. We may see basophilic stippling on the red blood cell smear, decreased reticulocytes, and a normal red cell distribution with normal serum iron, total iron binding capacity, and ferritin, and a significant increase in the free erythrocyte protoporphyrin, which is FEP. X-rays, again, may show lead lines in the distal metaphyses. We might see a radiolucency. This is more apparent with chronic lead exposure and is due to a growth arrest line. This table looks at how to treat lead poisoning based on the blood lead level. The first thing to note is that for all increased values under 45 micrograms per deciliter, there is no use of chelation. So beginning at 5 to 14 micrograms per deciliter, the first thing that we will do is to confirm with a venous blood lead level and repeat this in a month. If it is still elevated, the family needs to be educated regarding lead exposure and the level followed again in 3 months. For higher blood lead levels, that is 15 to 19, we would do the same as what I just said, but the level would be repeated in a shorter period of time within 2 months. For higher levels yet, 20 to 44, we will confirm with blood lead level in a week and notify the health department. These levels need environmental inspection of where the family is living and the determination of the lead exposure with appropriate cleanup and family education. The blood lead level is then followed to confirm a decrease back to normal. So from 45 to 70, that is just below 70, so 45 to 69 micrograms per deciliter essentially. We will perform a venous blood level within 2 days, complete the evaluation as I just said for all levels under the 45 micrograms per deciliter, and remove the child and the family from the environment. If this is not possible, the child is hospitalized. Chelation is done on an outpatient basis with oral succimer, or if hospitalized, IV EDTA can be used. The CBC and electrolytes and liver functions are monitored. For all blood lead levels of at least 70, that is 70 and above, the next step in management is immediate confirmation of the blood lead level and immediate hospitalization for IV chelation with 2 chelators, dimercaprol, which is a British anti-leukocyte factor, and EDTA. EDTA does not cross the blood-brain barrier, so additional chelators are sometimes used if there's an increased risk of encephalopathy. Congenital pure red cell aplasia or hypoplasia is known as Black Van Diemen syndrome. This is an inherited X-linked or autosomal recessive or dominant genetic defect of red blood cell progenitor cells leading to decreased red blood cell production. The clinical presentation is from birth to early infancy with findings of severe anemia and heart failure. In addition to having primarily red cell problems, they also present with short stature. They're short at birth, small at birth. They have various facial dysmorphic features, various renal anomalies, and characteristically have a triphalangeal or 3-boned thumb. The laboratory findings are a significant decrease in hemoglobin and hematocrit, where there's reciprocal increase in hemoglobin F. There's some degree of macrocytosis, so we actually see a slight increase in MCV with this anemia. They may have a normal to moderate decrease in their white cells with normal to increase in platelets. A bone marrow aspirate shows markedly decreased numbers of erythroid precursors with normal myeloid precursors and megakaryocytes, and this confirms the diagnosis. Initial therapy is with prednisone. Most will respond with long-term survival, but leukemia is a rare complication. The prednisone is then weaned to alternate day therapy, and the smallest dose is used to keep the hemoglobin about 10 grams per deciliter. For any failures, IV methylprednisolone first, and then anabolic steroids are used, and then chronic blood transfusions with chelation. Hematopoietic growth factor may also be used, and the long-term survival is with a bone marrow transplant if there is a histocompatible sibling. A 2-year-old presents to the physician with aplastic anemia. Patient has microcephaly, microphthalmia, and absent radii and thumbs. Fanconi anemia is a congenital pancytopenia that is an autosomal recessive cause associated with characteristic chromosomal abnormalities when cells are cultured. It is found in higher prevalence in certain ethnic and geographic areas. The median age of presentation is 7, but it can occur anywhere from birth to 50 years of age. Characteristic birth defects may occur, such as short stature, and particularly radial and thumb anomalies. This time, hypoplastic or absent thumb is the most common. Many other organ systems may be affected with abnormal findings. The first signs typically are petechiae, bruising, and bleeding, and then worsening anemia, and then finally repeated infections. This produces a pancytopenia. The red cells are macrocytic. There's an increase in hemoglobin F, and the bone marrow shows hypoplasia with loss of all elements, erythroid, myeloid, and platelet precursors. The diagnosis is therefore with bone marrow aspiration, and the cytogenetic studies can be done antenatally by showing chromosome breaks in cells at the time of doing a choriovital sampling or amniocentesis. Complications primarily are due to bone marrow failure, which is the major cause of death. Median survival is 30 years of age, and after this then the major complication is leukemia, primarily AML or myelomonocytic, and after this various solid tumors, particularly in older patients. The basic management is transfuse for anemia when hemodynamic changes occur, and platelet transfusions are given as well as neutrophils for significant decreases in those cell lines. Granulocyte colony stimulating factor is also used. The long-term treatment of choice is a stem cell transplant from an HLA-matched sibling, which prevents bone marrow failure and leukemia. Androgens are also used if the transplant is not an option. Various surgeries may be needed depending on associated abnormalities. Transient erythroblastopenia of childhood, TES, is a relatively common post-viral transient immune erythroid suppression with rapid complete recovery. The clinical presentation is typically between 6 months to 3 years of age in a previously well child with gradually increasing pallor and fatigue over a few days after a nonspecific viral illness. When the CBC is obtained, we see a normocytic, normochromic anemia with very low reticulocyte counts. By this time, the hemoglobin usually drops to between 5 to 7 grams per deciliter. The red cell smear shows normal red blood cell morphology. They may also have very mild neutropenia, but this, of course, is not part of the problem. The bone marrow, which is typically not needed, would show decreased to absent red blood cell precursors with other lines normal. The key is to realize the classic presentation of this in the presence of normal white cells and normal platelets, and no other physical evidence of lymphoproliferative disease, such as lymphadenopathy or hepatosplenomegaly. Management is with packed red blood cells if transfusion is necessary based on hemodynamic instability, and then the CBC is followed regularly with complete recovery, typical between 1 to 2 months. Anemia of chronic disease and anemia of renal disease occurs in children with any ongoing chronic disease and any form of chronic renal disease, primarily due to a decrease in the red blood cell lifespan with a mild to absent increase in erythropoietin. The labs are consistent. They're typically most commonly as a normochromic normocytic anemia with normal to low reticulocytes. Iron is decreased without an increase in total iron binding capacity, and ferritin is normal to increase. The primary treatment is to control the underlying cause, to use transfusions only as necessary for hemodynamic compromise, with the most important treatment in the long run being erythropoietin. The megaloblastic anemias are very uncommon anymore in children in the United States. They're caused from ineffective erythropoiesis, primarily because of severe malnutrition with folate or vitamin B12 deficiency. We see macrocytic anemia with underproduction, increased MCV, and decrease to normal reticulocyte count. The red cell distribution width is normal, and the blood smear shows macrocytosis with hypersegmented neutrophils, defined as neutrophils with at least 6 nuclear segments. They may also have a decrease in white blood cells and platelets. Folate deficiency, again, is very unusual and is usually due to undernutrition and or selective diet, such as a breastfeeding mother with poor nutrition. Folate is absorbed in the proximal intestine and circulates in the plasma as tetrahydrofolate, which is used primarily for purine biosynthesis. The lack of folate causes arrest of nuclear maturation, so there's nuclear immaturity with respect to the cytoplasm, and this leads to the condition of a megaloblastic anemia. The major causes are primarily decreased intake, like in infants on unsupplemented goat's milk, or decreased proximal intestinal absorption that one might see with malabsorption or certain medications, or with the use of antifolate medications such as methotrexate, sulfonamides, and azathioprine. Less commonly, we may have congenital tetrahydrofolate deficiency or an increased use of folate because of chronic hemolysis or pregnancy, or rarely increased loss. Findings are related to anemia. There are no neurological findings present. Other findings would be from malnourishment and possible abnormal stooling if there's any evidence of malabsorption. The best test is the red blood cell folate level, which also includes tetrahydrofolate. And the therapy is with folate supplementation and to change or eliminate the causative drug if this is the problem, to treat the underlying medical problem, whatever it may be. Again, B12 deficiency due to inadequate intake in children is rare. It would usually be because of poor maternal nutrition in a breastfed infant or young child. When we rarely do see B12 deficiency in children, it's usually due to pernicious anemia or some other primary problem. B12 binds to intrinsic factor in the stomach and is then transported to the terminal ileum where it's absorbed. It acts as a cofactor in enzymatic reactions and activation of folinic acid. DNA synthesis is impaired due to arrest of nuclear maturation from a decrease in folate derivatives. The primary causes, then, like with folate, are inadequate intake, inadequate absorption, such as in ileal disease, or decreased absent intrinsic factor, pancreatic insufficiency, parasitic illnesses, and intrinsic intestinal disease. It can also be caused from impaired transport from the intestines, which is familial and a very rare cause of this. The major findings are evidence of anemia and, again, possibly mild pancytopenia. Also in children are seeing glossitis, stomatitis, hyperpigmentation, decreased vibratory sensation because of the effect on the dorsal columns, and psychiatric changes, which primarily is dementia. The first step in management may be a bone marrow exam if more than one cell line seems to be affected and the diagnosis is not clear. The bone marrow shows asynchrony of the red blood cell precursors, that is, nuclear compared to cytoplasmic. The Schilling test is used to measure serum B12 before and after giving vitamin B12, and then again using B12 plus intrinsic factor, so that if the B12 increases after oral vitamin B12, this is a dietary cause. If B12 increases only with oral B12 plus intrinsic factor, we have pernicious anemia. And if there is no increase in B12 after intrinsic factor, it's due to one of many other causes. The therapy is vitamin B12 then, with or without intrinsic factor, depending on the underlying diagnosis. Hereditary spherocytosis and elliptocytosis are the major membrane defects. Most cases of both are autosomal dominant, but we can have autosomal recessive genetics. For instance, in hereditary spherocytosis, the autosomal recessive form is most commonly found in Northern Europeans. There's also in hereditary elliptocytosis a difference in severity with respect to genetic presentation. Autosomal dominant disease results in common mild disease, autosomal recessive in more severe types. In hereditary spherocytosis, the basic abnormality is due to ankyrin defects, which is a red blood cell cytoskeleton protein. This leads to abnormally shaped red blood cells that are hyperchromic microspherocytes. These get trapped in the spleen and are removed early to then produce extravascular hemolytic anemia. In hereditary leptocytosis, we have dysfunction of alpha and beta spectrum, but essentially the pathophysiology is the same as spherocytosis. The highest frequency frequency occurs in malarial zones. The most common presentation of hereditary spherocytosis is any age can be the presenting age, including hemolytic disease of the newborn. The severity and progression depend on the rate of destruction versus production of red blood cells. Most have mild to moderate anemia with a slight increase in spleen size and mild to moderate jaundice. They may also have episodes of acute exacerbated anemia with aplastic crises due to parvovirus B19 infection, or can have folate deficiency with chronic hemolysis, and this can lead to megaloblastic changes. Most cases of hereditary elliptocytosis are mild asymptomatic. We can also have silent carrier states, but again, like with hereditary spherocytosis, you can have severe transfusion-dependent disease with acute exacerbations and life-threatening hemolysis, depending on the type of disease and inheritance. Again, may present as severe hemolytic disease in the newborn, requiring exchange transfusions. The basic laboratory findings are anemia to various degrees with increased reticulocytes. Depending on the type and severity, you may have no or little anemia with no reticulocytosis to severe anemia with reticulocytosis. The smear of hereditary spherocytosis should show spherocytes and, of course, elliptocytes in hereditary elliptocytosis. In both cases, the bone marrow in the more severe cases would show erythroid hyperplasia. The MCV is normal with an increased MCHC and an increased RDW. The definitive test is the osmotic fragility test for both, and the reason this works is that these cells with abnormal membranes will tolerate less swelling when the red blood cells are suspended in a hypotonic salt solution. The management is primarily the same for both. Splenectomy is used for moderate to severe disease, which cures the anemia and the jaundice, but only partially eliminates hemolysis. We like to delay this until 3 to 5 years of age. Until that time, transfusions and even exchange transfusions in the neonate are used when hemoglobin is decreased and associated with hemodynamic compromise. As usual with hemolysis, folate supplementation needs to be provided. Pyruvate kinase is one of the two major enzyme defects causing hemolytic anemias. Pyruvate kinase deficiency leads to depletion of products of glycolysis, particularly lactate and ATP. The depleted ATP then leads to loss of potassium and water across the red cell membrane with cell contraction, which results in premature splenic destruction. It is autosomal recessive and particularly found in descendants of people from Northern Europe and China. The severity varies widely from mild disease presenting later in life to severe hemolysis in the newborn with anemia, jaundice, and splenomegaly. Laboratory findings show a normal chromic normocytic anemia, that is Coombs negative, with reticulocytosis and an increased RDW and an increased bilirubin. Bone marrow shows erythroid hyperplasia and active marrow. The enzyme assay usually shows a decreased level of pyruvate kinase, but this may not always be the case, and currently the definitive diagnosis is with PCR. Management is exchange transfusion and phototherapy in the newborn, and then transfusions for symptomatic anemia and splenectomy reserved for moderate to severe disease. A 2-year-old boy presents to the physician's office for an ear check. The child had an ear infection that was treated with trimethoprim sulfamethoxazole 3 weeks earlier. On physical exam, the patient is noted to be extremely pale. Hemoglobin and hematocrit were found to be 7 grams per deciliter and 22% respectively. G6PD deficiency is the most common abnormality of the hexose monophosphate shunt. Low production of NADPH leads to decreased glutathione peroxidase and reductase, so glutathione becomes oxidized. This leads to the production of methemoglobin and sulfhemoglobin, which causes denatured hemoglobin that precipitates as intracellular inclusions called Heinz bodies. These cells are then removed within the spleen. The disease is higher in Mediterranean, African American, Chinese, and people of Northern European heritage. Most cases are X-linked. Most patients have the episodic hemolytic form, so they have minimal or no hemolysis unless they are exposed to an oxidative stress. The most common drugs and conditions are infections, primaquine, pamaquine, sulfonamides and sulfones, nitrofurans, aspirin, probenecid, dimercaprol, acetaminophen, naphthalene, and favabeans. With exposure of these oxidants, there is acute onset of pallor, jaundice, hepatosplenomegaly, abdominal pain, dark urine, tachycardia, and depending on the degree degree of hemolytic anemia, possibly shock. Newborns may present with neonatal jaundice, especially in those newborns who are of Greek and Chinese ancestry. Less common then is the other form, which is a chronic non-spherocytic hemolytic anemia, which is more common in Northern European, Mediterranean, Asian males, particularly presenting with neonatal jaundice. Laboratory studies during hemolysis show increased bilirubin, LDH, plasma hemoglobin, decreased haptoglobin, and urine with free hemoglobin. There's a normal MCV, increased RDW, and reticulocytosis. The smear has fragmented red cells, which we call bite cells, polychromasia, microspherocytes, and normoblasts, and a supravital stain is positive during hemolysis for Heinz bodies. Various screening tests are available, such as fluorescent dyes. If they are positive, then a quantitative enzyme assay is definitive, and this should be performed. Basically, the management is supportive treatment for acute hemolysis, that is, transfusions is needed, and a splenectomy in moderate to severe cases, mostly in patients with the chronic hemolytic form. A 6-month-old African-American infant presents to the pediatrician with painful swollen hands and swollen feet. The sickle cell anemia is defined as any genotype that contains at least one sickle gene, with hemoglobin S making up at least 50% of the hemoglobin. Hemoglobin S results from a substitution of valine for glutamic acid at the number 6 position of the beta-globin gene. In homozygous disease, which is autosomal recessive, only hemoglobin S is produced. We also have compound heterozygotes, however, such as hemoglobin S with hemoglobin C or hemoglobin S with beta thalassemia. There are many other examples. In sickle cell trait, which is hemoglobin AS, the amount of hemoglobin S is less than 50%, with rare complications and normal lifespan. In the United States, sickle cell is prevalent in African Americans. The pathophysiology is that hemoglobin S carries oxygen normally, but once the oxygen is unloaded, the red blood cells become distorted, and after multiple deoxygenation cycles, there's permanent damage. This results in hemoglobin S polymerization and red cell sickling under low oxygen conditions. The abnormal red cells then interact with the vascular endothelium and lead to inflammation and vasoocclusion. Ultimately, there's a reversible red cell damage, and this results in hemolysis. The bone marrow cannot compensate with an increased production, and so we wind up with moderate to severe anemia. When the newborn screen is performed by liquid chromatography, we need to test all abnormals, again at the very first pediatric visit, again at 6 months, and perform hemoglobin electrophoresis of both parents if it has not been done already. First, we will have a hemoglobin screen with hemoglobin F in the greatest quantity, followed by hemoglobin S. The compound heterozygotes are suggested by other patterns depending on what hemoglobin is that's present. These are much less common. The smear will show anemia, reticulocytes, nucleated red cells, target cells, and sickle cells. Early functional and then anatomic asplenia by 5 years of age in all occur along with other immune dysfunction, and this leads to a risk of bacterial infections, especially with encapsulated organisms, particularly strep pneumoniae, Haemophilus influenza type B, and Salmonella species. And patients can present with sepsis, pneumonia, meningitis, and osteomyelitis. Again, with osteomyelitis, Staph aureus is the most common organism overall, but Salmonella is particularly increased in sicklers and, for that matter, in any patient with hemolytic anemia. Because it is not possible for us to differentiate in these children between bacterial and viral infections with febrile illnesses, the rule is that they are admitted to the hospital for complete culturing and empiric parenteral broad-spectrum antibiotics until the cultures are negative. There are 2 acute hemolytic episodes to consider. The first is the aplastic crises, and this can occur again with any hemolytic anemia. This occurs with infection with parvovirus B19, which leads to acute, significant, and sometimes life-threatening decrease in hemoglobin with a large reticulocytosis. Transfusions are generally necessary until the marrow activity is restored, and in most cases, immediate transfusion is an emergency procedure. The other acute hemolytic crisis is the acute splenic sequestration. This occurs typically in the first 5 years of life, but is not very common. The first 5 years because there is still persistence of some splenic tissue. And again, like with the aplastic crisis, we have the acute onset of life-threatening anemia with significant reticulocytosis, but this time with abdominal distension due to blood suddenly pooling in the spleen for unknown reasons. Just like with the aplastic crisis, these patients need emergent transfusions, and generally once this is diagnosed, they have prophylactic splenectomy because of common recurrences. The most common feature overall are the vaso-occlusive episodes with ischemia presenting as pain, and they tend to involve bone with the most marrow activity, so that the earliest involvement is with the metacarpals and metatarsals beginning at 6 months through 2 years of life, producing the acute distal dactylitis or hand-foot syndrome. This involves symmetric swelling of the hands and or feet. With increasing age, however, we primarily have involvement of the long bones and then ultimately the vertebrae during adolescence. Precipitators of ischemic events are hypoxia, dehydration, acidosis, and hypothermia, infection, and stress. Ischemic vaso-occlusive attacks occur more in the central body areas as opposed to the extremities with increasing age, and may even occur in the absence of any obvious precipitating factors. There are a number of other more severe vaso-occlusive episodes. The first is the acute chest syndrome, and this is simply defined as a new density on chest x-ray in combination with pain, a fever, and respiratory distress. Most underlying causes in children are felt to be due to infection, and the most common are from strep pneumoniae, mycoplasma pneumoniae, and chlamydia pneumoniae. Other etiologies are possible, and they include pulmonary infarction, atelectasis, and fat embolism from a bone marrow infarction. The basic management of acute chest syndrome is to obtain a chest x-ray as soon as possible, start the patient on oxygen, IV hydration, and to provide analgesia that does not suppress respiration. Empiric antibiotics, broad spectrum, are started after the patient is cultured, and a blood transfusion is needed for hypoxemia, increasing respiratory distress, or a previous admission for acute chest syndrome. If there is lack of improvement within several hours, an exchange transfusion should be performed. Next is a priapism, which is defined as involuntary erection lasting more than 30 minutes. Episodes lasting longer than about 3 to 4 hours can result in fibrosis and impotence. The initial treatment here should be with oral analgesia and sitz bath. If it goes on for greater than 4 hours, however, blood is aspirated from the corpora cavernosa, followed by injection of dilute epinephrine. Neurological complications are primarily focal neurological defect, and the most common presentation is hemiparesis. Any deficit lasting more than 24 hours or any MRI lesion is consistent with an infarct and is correlated with the clinical deficit. Patient may also have headache, seizure, or central venous thrombosis. The basic management issues here are oxygen and blood transfusions very quickly to raise the hemoglobin up significantly, and then exchange transfusion to decrease the hemoglobin S. Immediate CT scan is the diagnostic study of choice to include hemorrhage, and then should be followed by the better MRI. There are a number of things that we do after this happens for primary prevention. In the future, blood flow can be followed with transcranial Doppler ultrasound, and the patient can be administered prophylactic blood transfusions to maintain a low level of hemoglobin S constantly. Renal disease occurs very commonly in sickle cell disease, and the presentation can be with a nephrotic syndrome, an infarct, most commonly papillary necrosis, and less commonly renal medullary carcinoma. Generally, we have children and adults with chronic renal failure and the need for dialysis and ultimately renal transplantation. Other complications are numerous, and they include pulmonary hypertension, cholelithiasis and cholecystitis, avascular necrosis of the femoral or the humeral head, retinopathy, psychosocial problems, cognitive and developmental delays, poor growth, and delayed puberty. Some specific issues with respect to management have been discussed already with the appropriate vaso-occlusive episodes. In general, with any vaso-occlusive ischemic episode, pain must be controlled adequately, and mostly this can be done on an outpatient basis with acetaminophen, non-steroidal anti-inflammatory drugs, increased oral hydration early in the course, and then even codeine or oral morphine derivatives with more moderate pain. Admission to the hospital should be done for IV opiates for peak pain, and we now use continuous infusions with fentanyl or nalbuphine. Also in older patients, we use patient-controlled analgesia. IV hydration and blood transfusions will not alleviate pain by themselves and should be used only with clinical dehydration and or a hemodynamic decrease of hemoglobin. Hydroxyurea is now used in children as it is in adults. It raises the hemoglobin F and hemoglobin level in general and is the only effective drug to reduce the frequency of painful episodes. If given daily, however, there is a short-term adverse effect of of myelosuppression, and the long-term effects are not yet known. So it's currently used selectively in children who are at least 5 years of age who have had multiple painful episodes. Oral daily penicillin prophylaxis beginning at age 2 to 4 months of age is used in addition to routine immunization with PCV13. Additional doses of the PPSV23 should be administered after age 2. And finally, an allogeneic bone marrow transplantation is curative, but we have to have HLA-compatible full sibling and a patient younger than 16 years of age with hemoglobin SS or hemoglobin S beta thalassemia major with a history of a severe disease. And no other form of sickle cell are currently being treated with bone marrow transplantation. The thalassemias are inherited disorders of hemoglobin synthesis, so we have abnormal formation of globin genes, which leads to an imbalance with the other normally produced chains. The other normally produced chains then accumulate in the cell as an unstable product and leads to cell destruction. In alpha thalassemia, alpha globin production reduced to absent, and there's a relative excess then of beta and gamma globin chains. In the fetus, gamma tetramers are formed. This is called hemoglobin BARTs, and after birth, beta tetramers are formed, which is called hemoglobin H. There are 4 alpha globin genes due to a gene duplicated system, and the majority of clinical presentations are then the result of complete deletional mutations, and so there are 4 alpha thal syndromes. Alpha thal silent trait is due to deletion of 1 gene. It's common in African Americans and has no clinical expression. The newborn has only very small amounts of hemoglobin BARTs, and it's usually identified if a sibling has 2 or 3 gene deletions, and familial screening is then undergone. It is not found, not identified by hemoglobin electrophoresis, as there are no abnormal hemoglobins and no relative increase in any hemoglobin, and so you need molecular analysis for this. Alpha thalassemia trait is deletion of 2 genes. Again, African Americans are the primary people involved in the United States and people of Mediterranean descent. They typically will present with a mild hypochromic microcytic anemia with a normal RDW compared to iron deficiency without any clinical problems. However, when laboratory studies are done looking for the possibility of iron deficiency anemia, it is most often confused with iron deficiency anemia. It is also not identified by hemoglobin electrophoresis, as there are no abnormal hemoglobins and no relative increase in hemoglobin, and therefore, again, you need molecular analysis for the diagnosis. The diagnosis is suggested, for instance, in a child of 1 year of age who comes in for routine well child care, in which case anemia is screened for at that age. The child is found to have a microcytic hypochromic anemia, but because of the normal RDW compared to the significant increase in RDW and iron deficiency, the diagnosis of thalassemia trait is made, in which case a hemoglobin electrophoresis should be performed next. As we will see momentarily, hemoglobin electrophoresis is going to identify all cases of beta thalassemia, so that if it is identified as beta thalassemia, that's the diagnosis. If not, then it's going to be alpha thalassemia trait, in which case, again, molecular genetics is needed to confirm the diagnosis. 3 gene deletions is called hemoglobin H disease, and in this case, hemoglobin BARTs is greater than 25% in the newborn period and is easily diagnosed with hemoglobin electrophoresis. At least 1 parent has alpha thalassemia trait. Later, we then have the development of beta tetramers. Again, this is called hemoglobin H, which these tetramers interact with the red cell membrane and can be identified electrophoretically. The blood smear and indices will show microcytosis and hypochromia with mild to moderate anemia. Typically, the hemoglobin is 7 to 11 grams per deciliter. There may be target cells, mild splenomegaly, jaundice, and cholelithiasis. But even with this, these patients typically do not require transfusions or splenectomy. In the United States, we see this most commonly in Southeast Asian populations. Finally, alpha thalassemia major is 4 gene deletions, and this results in severe fetal anemia, causing hydrops fetalis in the immediate newborn period. The newborn has predominantly hemoglobin BARTs with only small amounts of other fetal hemoglobins. There is severe anisocytosis and poikilocytosis. Immediate exchange transfusions are needed for any possibility of survival, and if so, they are transfusion dependent, and the only long-term cure then is with a bone marrow transplant. There are only two beta-globin genes, one on each chromosome with no duplication, and variation in beta chain synthesis occurs mostly due to single base changes, leading to partial reduction. If there is a gene deletion, then there is complete absence of beta-globin production. And this is called thalassemia major, which is also known as Cooley's anemia. There are therefore more than 200 mutations that I've identified. Mostly there are 20 common alleles, which represent most cases around the world. Once again, in this case, we have excess alpha chains, which form tetramers. They precipitate in the cells and cause cell destruction, as I previously described. In the most severe forms, the maturation of red cells is disrupted within the bone marrow, resulting in ineffective erythropoiesis. There is a significant increased production in gamma chains because of increased hemoglobin F, and in the milder forms also delta chains because of an increased production of hemoglobin A2. Beta thalassemia can then be qualitatively found presenting anywhere from beta thalassemia trait to beta thalassemia trait, which will present similar to alpha thalassemia trait, and then thalassemia minor, intermedia, and thalassemia major, which is Cooley's anemia. In thalassemia major, there's progressive hemolytic anemia, hypersplenism, poor growth in the first months of life, and depending on the amount of hemoglobin F, which is quite variable, a low amount of hemoglobin A2. Transfusions are typically required beginning at age 2 months to 2 years of age. Severe anemia results with few reticulocytes because of this ineffective erythropoiesis that I described. There's a significant increase in RDW, in this particular case, nucleated red cells, microcytes, and no normal appearing red blood cells. It's because of the fact that the red cells are so abnormal in size and shape that in Cooley's anemia, the RDW, like in iron deficiency, is increased. There's also increased serum bilirubin, increased serum ferritin and transferrin saturation because iron accumulates even without transfusions, and there's also nutritional hemosiderosis because the anemia is so severe, the body tries to extract all the iron that is possible, and it does so from additional iron absorption from foods, and this then produces what is called nutritional hemosiderosis. Without transfusions, there would be cardiac decompensation, and medullary hyperplasia typically occurs, particularly with maxillary hyperplasia, frontal bossing, and an expanded medullary space of the skull with massive widening of the diploic spaces, producing the so-called hair-on-end pattern. Pathological fractures may occur, and there is significant hepatosplenomegaly. Chronic transfusions are necessary for health and prevention of complications, but this, of course, leads to transfusional hemosiderosis, which is avoided to some extent with iron chelators, such as deferoxamine. The best method of determining iron stores is by doing a liver biopsy to guide the specific use of chelators, but unfortunately it doesn't correlate to cardiac overload. The major side effects of deferoxamine include bone dysplasia, ototoxicity, and retinal changes. The deferoxamine chelates iron, allowing excretion in the urine and the stool. There are newer iron chelators that have been FDA approved for children greater than 2 years of age, and they are better at removing cardiac iron, which is the major cause of death, that is cardiac hemosiderosis. Other problems include endocrinopathies with decreased growth, delayed sexual maturation, diabetes, hypothyroidism, and even hypoparathyroidism. And the best long-term cure rate was with a bone marrow transplant from HLA-matched siblings in children under 15 years of age without hepatomegaly or without excessive iron stores. For the purpose of this exam, after obtaining the history with respect to hemorrhagic disorders, we can, for the most part, classify them into two large groups. On the right, you can see are the clotting factors. When we have an abnormality of one or more clotting factors, the typical presentation is with deep bleeding, with extensive ecchymosis and hematomas, or platelet number or platelet function abnormalities, such as we see with von Willebrand disease and in many other cases. This is going to cause mucous membrane bleeding with petechiae and ecchymosis. Of all of the congenital coagulation disorders, 85% are factor VIII deficiency, which is hemophilia A, 14% are factor IX deficiency, which is hemophilia B, and all the others together are 1%. All racial groups around the world have found to be affected, and the most common inheritance pattern is X-linked. But females can be affected if they are homozygous or perhaps with extreme lionization. The abnormality in hemophilia is slow clot formation. That is, the platelet plug forms, but is not reinforced by a fibrin clot. The severity of the disease is dependent upon a wide variety of genetic defects, with coagulation factor levels at least 5%, which is classified as mild disease, 1 to 5%, which is moderate, or less than or equal to 1%, which is severe. Carriers are not symptomatic with factor VIII deficiency, but there may be an increased bleeding with factor IX deficiency if that patient has significant trauma. The more severe the abnormality, the earlier and more severe is the bleeding. Bleeding may occur after birth, like with circumcision, and a small number even develop an intracranial hemorrhage. The major types of bleeding are hemarthrosis and deep muscle hematomas. Mild cases may not be diagnosed until there's major trauma. Repeated bleeding leads to joint destruction, muscle weakness, damage due to compression, and then atrophy. There may also be GI and genital urinary bleeding, bleeding with tooth eruption or dental extraction, or severe intracranial hemorrhage that can even result in death. Laboratory studies are a normal bleeding time, an increased activated partial thromboplastin time, that is the APTT, a normal prothrombin time, the PT, and a normal thrombin time. Each factor can then be specifically assayed, and inhibitors are tested for by incubating the patient's plasma with normal plasma and determining whether there is neutralization of the factor that is tested for. Carriers have a factor VIII activity to von Willebrand factor antigen ratio of less than 1, where the normal is 1 to 1. Fetal testing can also be performed if the mutation is known, with restriction fragment length polymorphism, or even with gene sequencing if it is unknown. Recombinant factor VIII products for mild to moderate bleeding are used. The factor levels must be raised to 35 to 50%, and with major bleeding to near 100%. And there are specific protocols for all types of bleeding which specify the dose per kilogram, frequency, and the length of time that it should be administered. Desmopressin acetate, which is given intranasally, is used for mild disease. It releases the patient's endogenous factor VIII. It is not, however, effective for factor IX deficiency. With severe hemophilia, prophylaxis with the first hemorrhage, that is factor VIII via a central venous catheter administered every few days to keep a minimal factor level, is now the standard of care. It's been very effective in preventing chronic joint disease. If a bleeding episode has not responded to replacement therapy, then inhibitors have probably developed. These inhibitors are less common with factor IX, and so these patients then need to go through a desensitization process. If this fails, bleeding is then treated with high-dose factor VIIa or activated prothrombin complex concentrates. Von Willebrand disease is the most common hereditary bleeding disorder. There are different variants depending on the mutations coding for different functional domains of the von Willebrand factor, which resides on chromosome 12. The inheritance is autosomal recessive, but girls are more commonly affected. The basic physiology is that von Willebrand factor adheres to the subendothelium after vascular damage. Platelets then adhere through the glycoprotein receptor. The platelets then become activated, and additional platelets are recruited. Factor VIII is brought because it's carried with the von Willebrand factor, and then further steps in regulation occur. The hallmark is mucocutaneous bleeding, that is bruising, epistaxis, or even menorrhagia. While there are 7 different types of von Willebrand disease, type 1 is the most common. In type 1, the protein is reduced but not absent. The various laboratory findings can be wildly different in different cases of von Willebrand disease, anywhere from normal to increased to significantly increased, and therefore a combination of studies are done. For instance, in the most common type 1 von Willebrand disease, there's often normal bleeding time, but it can be normal to significantly increased, and the APTT can be normal but abnormal in severe cases. And so the general feeling is that no single assay can rule out the disease, and testing needs to include quantitative assay for the von Willebrand factor, the von Willebrand factor ristocetin cofactor activity, factor VIII activity, determination of von Willebrand factor multimers, ristocetin-induced platelet aggregation, and platelet count. The diagnosis is based on finding at least one low level of any of these measures. Elevating the level of von Willebrand factor permits normal recovery and survival of factor VIII because its gene is normal. In type 1, DDAVP releases von Willebrand factor from endothelial cells. If there is not an adequate response, again more commonly with different forms of von Willebrand disease, then replacement therapy needs to occur, and this is done with plasma-derived von Willebrand concentrates, which also contain factor VIII. Minor bleeding can be managed with a combination of DDAVP and antifibrinolytic therapy. Hemorrhagic disease of the newborn occurs if vitamin K is not administered after birth. Lack of maternal free vitamin K and the absence of newborn intestinal bacteria leads to decreased vitamin K dependent factors, which are 2, 7, 9, and 10. While they are decreased at birth, they commonly will increase by about 7 to 10 days of life. Without vitamin K after birth, the infant will have early onset of bleeding, generally from birth to 24 hours, manifested mostly by bleeding from the umbilical cord, circumcision, and mucocutaneous bleeding, but it can also be more severe, gastrointestinal, intracranial, or scalp bleeding. Diagnostic lab studies include an increase in the prothrombin time, the PT, an increase in the partial thromboplastin time, the APTT, and in the blood coagulation time, with a decrease in the vitamin K dependent factors. Prevention, obviously, is with intramuscular injection of vitamin K immediately after birth, and this then prevents bleeding in full-term infants, but variably in preterm infants. Treating for bleeding may then be given with vitamin K at 1 to 5 milligrams intravenously injected, and fresh frozen plasma for any significant bleeding. Bleeding may be a common feature of any significant liver disease, as all clotting factors are produced in the liver except for factor VIII. The decrease in factor level, and hence the degree of ongoing bleeding, is proportional to the hepatocellular damage. Generally, treatment is treating the underlying disease, if that is possible, and the first principle of treatment with respect to the bleeding itself is the administration of fresh frozen plasma. A 4-year-old child previously healthy presents with petechiae, purpura, and excessive bleeding after falling from his bicycle. Immune thrombocytopenic purpura, ITP, is a post-viral, typically 1 to 4 weeks after a nonspecific viral infection, acquired immune-mediated platelet destruction because of antibody-coated platelets that are then recognized by the Fc receptor of the splenic macrophages and are removed. Typically, it's going to present in a young child with a sudden onset of petechiae and purpura, and possibly in more severe cases, mucocutaneous bleeding when there are very low platelets. The physical exam is otherwise normal. That is, there's no other suggestion of a lymphoproliferative illness, such as hepatosplenomegaly or lymphadenopathy. Most resolve within 6 months, but 20% go on to have chronic ITP, for which there's usually an underlying cause, which may eventually be found. Very few have the most feared complication, which is intracranial hemorrhage. Platelets at presentation are usually less than 20,000, and the platelet size is normal to increase. Again, there's a normal hemoglobin unless there's been significant ongoing bleeding, normal indices, normal white cell count, and differential. A bone marrow aspirate is not necessary, but it would show increased megakaryocytes with more immature forms. The bone marrow aspiration, in fact, should only be performed if any other cell line is affected or if there is any other evidence of a lymphoproliferative disorder on physical exam. Adolescents presenting with this, because it becomes much more common, should be tested for lupus, and HIV should be considered in the sexually active adolescent. Treatment for mild to moderate illness when platelets are greater than 20,000 with no significant bleeding should just be to follow the patient. Families should be provided with education and counseling. IVIG is used first for more severely affected patients or with ongoing bleeding, and is used for 1 to 2 days. Generally, the effect will be an increase in the platelet count to significantly more than 20,000 in most. If they are unresponsive, corticosteroids may then be used until the platelet counts up above 20,000, and then it should rapidly be tapered. Platelet transfusions are generally contraindicated because the antibodies will bind to the autologous platelets unless there's life-threatening bleeding and it can't be controlled with other means. Chronic ITP then is defined as continued thrombocytopenia for at least 6 months. Other diseases should be evaluated for, such as autoimmune disease, HIV, and other non-immune causes of chronic thrombocytopenia. A splenectomy is usually successful in inducing a complete remission.